on to the next session, I would like to invite our next speaker for the day, Ms. Shaon Sengupta. She is currently heading the India Design Studio of Philips, and in her current role as the design director, she partners with innovation, business, and market to co-create healthcare solutions. She is set to create strategic competencies like service design, data design, and design strategies besides UX design as the core competence in her studio. She's won multiple design awards for her work. Over to you, Ms. Sengupta, to deliberate on very important topic in the current times, that is diversity in the context of healthcare.
Sure. Thanks a lot, Pooja. I'll get started with sharing my screen. Just let me know if you can see it.
Yes. I can see it, yeah. Please.
Okay, great. Yes, indeed, this is a topic very, very close to our hearts as designers. And while, we are handling our challenges, our design, let's say, perspectives around this particular topic, I believe that it is also time for all of us to reflect on what Piyush already set as a stage of designing for all. And it's not so much about, we as designers really making our cut into designing world-class products. Of course, that is a vision in any case, but it is also about making sure that the solutions and the products that we design are definitely taking into consideration the very, very important aspect of inclusivity and also diversity. So over here, my specific topic would be around designing for low resource settings. And again, this has been something that I've been passionate about over the years. And I would love to share certain aspects from the field. As a large company like Philips, of course, we have our footprint into very, very sophisticated markets like Europe, America, and you name it. But at the same time, we are also absolutely passionate about, designing for the underprivileged, the underserved, as well as regions or population masses that probably are not absolutely benefited by the latest churn of technology and the aspects that it brings about. So indeed, innovation is a topic that is hand in hand, synonymous to what we as designers absolutely believe in. And I mean, it is mighty powerful, no doubt about that. But over here, the power of innovation is also about making sure that the true power actually, or the true test of innovation is absolutely about, making sure that whoever we are designing for at the end of the spectrum or at the bottom of the pyramid are as leveraged and as benefited as someone probably who are probably more or less the recipients of the front runners of this particular care program that we are looking at. So indeed, we will be talking about delivering this equitable care. We are talking about going into the bottom of pyramid, beyond business models and beyond our, the cost factors that, of course, is indeed a pertinent thing. But I think it is so important, and it's not just about my thoughts, it's also about figuring out what really are the pain points over there. So indeed, we will be looking into, environments, challenges, and also aspirations around some of the settings such as this. And like I said, I have certain pictures from the field in order to trigger you, because a lot of times we kind of think that we are empathizing, but not always. And the realities of the settings are quite different from probably what our mental model permits us to think. Just even before we go there, I think it's interesting for all of us to reconvene and look into, what are the top challenges, for example, that we are looking at when we are talking about regions or populations such as this. And to do this, we have done like a very thorough analysis around, rural parts of China, India, Indonesia, Brazil, and Kenya. And we realize that the aspects of these gaps or the challenges remain pretty much common or pretty much similar, if we have to say so. The first thing first is indeed about the lack of infrastructure. And we are talking about really basic infrastructure like power, like, connectivity and things like that. We are talking about patient awareness, where of course the onus of healthcare is in our hands, but what to do about it, how do we seek care, how do we make sure that we are also proactively looking for our health and well-being, that is pretty low in these contexts. And at the same time, we also have, like prevalence of or unreliable caregivers, for example, who are not trained on the job, who are probably trying to fix certain things in ways that are not conducive to your recovery. Moving forward, also the population is largely curative care focused, so which means only if a symptom is very pertinent, you would actually go out and see your doctor. Otherwise, you would keep quiet. And even if you choose to go ahead and see your doctor, the fact that the care facilities remain so inaccessible, also maybe away 20 kilometers or 30 kilometers, connecting you to the basic healthcare facilities, remain an equal challenge. And not to forget the fact that once you're out of the hospital or out of your clinic, your patient record that really aids in order to make a solid analysis of your health going forward is also lost. So we have very fragmented healthcare systems within geographies such as this. Now, with that as a context, let's also deep dive into some of the realities from the field, right? And I would focus a little bit more on this slide rather than the rest, because I would like you to have a glimpse of what are we talking about when we are talking about these realities, right? So the first one, and again, these are pictures from this field, so you would see that, a lot of times it totally changes the way we have probably gone ahead and assumed certain things. So you would see that while we are designing and developing really interesting solutions, sophisticated solutions that channel in artificial intelligence, machine learning, and so on, but the countries or the regions that we are looking at, deploying these solutions have absolute unreliable power supply. And here we are indeed talking about some as power supply as in the basics of generated power, electricity and things like that. So that was the first thing. Second was about very painfully slow connectivity, and here it is about poor internet and patchy network. So indeed, we can only imagine that it is so much beyond just providing solutions that are meaningful, but also making sure that they are used and you have the environment conducive enough for the users to be using it. Not to forget, we of course think about interesting solutions that would be probably used via our iPads or mobile phones, but you would also see the aspect of safety, which brings about the threat like theft and things like that. That plays another important role, because if you see over here, even the desktop is protected via like a metal cage, so that it does not encourage any theft or aspects around that safety. Then you would also in the row below, you would see that we have these admins for whom we develop solutions like the EMR, like a registration solution. But in spite of having the softwares or the hardwares necessary, which you see on the picture below, they are still using paperwork, and that is more often than not the reality beyond once we have designed or developed a very successful product. And not to forget, when we are talking about patient consultation, it is also to do with back and forth conversation. It is also to do with understanding your history, your evaluating your vitals and aspects related to knowing your patient. But here we are looking at giant and massive patient load, where maybe a time to a consultation is just about 2 minutes. And in that 2 minutes, how much can you really know about the patient, and how much of a value add in terms of understanding the right disease factor or proposing a right way forward in terms of your clinical coordination becomes really challenging in that case. And not to forget the tech literacy itself. Indeed, we are designing a lot of solutions, services. We are moving from a product company to being an essential software or a services organization. And it's not just true about Philips. It's true about all of us around who are following this digital transformation. But the ones who we are designing for, maybe, they're in terms of the literacy, in terms of their adoption, there are so many models around tech adoption as well that plays a very, very crucial role in which the way we envisage and the way it is used, there is a huge gap. And this gap is only increasing as and when, the solutions and softwares are becoming more sophisticated than the past. So I would just take you through some of the aspects, not really deep diving. So indeed, about low patient awareness, you would see that there is absolute non-compliance to treatment medication, or in terms of the lack of follow-up itself. Also, the predisposition of certain geographies that makes them more susceptible to have like comorbidities or a life-threatening disease like CVDs and so on. In fact, that is also a consideration that we have to make. Moving on, in terms of curative care focus, like I told you, there is no screening and there is no triaging of cases. Things are taken care only after it's too late. And that is often like, a point of no return. And when we are looking at a population where, it is more about really getting into the scheme of things, or really getting into a mode where your care, the care providers can actually make a difference, it becomes too late. And in this case, it is absolutely about the mindset and behavior change that I think we all can resonate with in this case. In terms of unreliable caregivers as well, of course, we have these rampant fake practitioners, but at the same time, we also have very untrained personnel who administers a certain dose on you, or maybe helps you move ahead with your treatment or your self care plan and aspects related to your own recovery. So that is again a pertinent challenge that we need to definitely take stock on and move forward. And again, most of it is probably very relevant for all of you, but just to recollect some of the things. You have this lack of necessary infrastructure for sure. You also have this lack of robust diagnosis. So we talk about treatment, but we are not so much talking about screening, triaging, diagnostics, making sure that you're also, designing for healthcare for the people who are already healthy, and not necessarily designing healthcare or thinking about solutions for the sick population or the ill population. And in order to make that happen or make that a reality, it's very important that care is all around you, and it's all about care coming to your doorstep. And even if that happens through our midwives or ASHA workers, right now it is largely focused on maternity and childcare, and that's pretty much the trend across these geographies that we looked into as well. Again, quickly around fragmented healthcare systems, no referral chains. For example, if something is wrong with me and if only I as a patient want to go back and see my doctor, would that chain be closed? Otherwise, it's forever broken, right? And the fact that who owns the patient history, or who owns that record of patient condition, is also a topic of debate, whether it's owned by your GP, whether it's owned by you as a patient. It is a massive cluster of ambiguity and uncertainty, and at the end of it, the person who suffers is the patients that we are looking at. So indeed, when we have looked into some of the realities of these settings, it is also important to understand who are the facilitators or who are the recipients of this care, right? Because at the end of it, we would be then only designing for something or some context that doesn't have the semblance or the bearing of the kind of challenges that we have looked at. Now let's look into this diverse list of, let's say, the kind of users that we are looking at from an end-to-end diversity and equitability standpoint, right? So let's for a moment consider that, okay, we are designing for community workers, but this community worker perhaps is semi-literate. Maybe she is just, past high school, and that's about it, or not even that. You have a physician who is really well renowned, but who is elderly, and hence tech related adoption, etc., kind of becomes a challenge. Then you have a nurse who is semi trained. Perhaps she has to double up as a receptionist or an admin and things like that. Then, of course, the challenges become really difficult. Then you have an admin, perhaps, who is semi-skilled. Maybe they just have a DTP knowledge, and that's about it. And then how do you really make your solutions viable and usable for them? And also, of course, to top it all, you have the patient who is not, not aware or not responsible for their own healthcare behavior. So with this, I think to reflect back, right? This is the reality that we are talking about. And in the future slides, we will be talking about, okay, as designers and as innovators, this is some reality that we can't change, and we can't change overnight. These are going to stay with the population that we are, the kind of population that we are looking at. So instead of changing the recipients, how do we as designers perhaps change our game? And also, how do we perhaps, get into the trenches and try to understand and empathize, a word that we are very fond of, but what does it really mean to empathize? So let's think about, from designing solutions to curating solutions that matter, and curating solutions that can be, offered and deployed, and also at the end of it, used for that matter. So let's see how. We would be indeed talking about locally deployable solution. And what does that mean? Taking into account that they are suitable for such settings, for low connectivity, for very, very patchy IT infrastructure, for example, and arranged by semi-skilled personnel. I mean, that itself is a challenge as designers that we need to tackle and handle. For example, for facilitation, for troubleshooting, for servicing, because your job as a designer doesn't end once a solution is out there in the market. It's also a lot to do with how do you service your solution, how do you make sure that you trained the right users in the right manners and things like that. And these solutions are used by semi-literate caregivers. So how can it still be easy to use by nurses or community workers to deliver care? Having a preventive care backbone, because you can't really trust on changing the mindset of patients, or you cannot really have doctors constantly chasing, because I spoke about the the mammoth caseload and the patient load that they anyway have to deal with. So here, how can the solution itself effortlessly help you to make things curative care focused, maybe through data, maybe through identifying insights that are already talking about population health, and indeed through hub and spoke delivery model, because here we are, we have been speaking about telehealth, we have been speaking about hub and spoke delivery model, but just to also leverage local competence, also leverage, what your context is good at, and tying it up with your hub delivery. That is where the true, meaningful, or the kind of absolutely accessible or care mechanism going forward I think it lies. Then not to forget the fact that it is also, triggering a little bit of behavior change, and making sure that you're also using the right tone and the right language. Of course, language or change of language is one of the most simplest thing to do. But how through the tonality, or how through your engagement do you also combine the patient and make him or make her a part of your care delivery system? So here, maybe in my last 5 minutes, I'll be speaking about, a little bit of specifics of what it means, rather than going about it a little bit high level, because indeed high level principles can serve as a lot of directions going forward. But over here, since we have worked across a lot of areas such as this, it would be really interesting for me to share some of the directions or takeaways, so that you as young designers, or as practicing designers who are using or who are designing for the context of healthcare, can also benefit from this. So the first thing first, if we have to answer the question as to how do you really make these solutions deployable into these local contexts, right? And the design principle would be making sure that the key goals are achieved in optimum time. And that's where the crux of everything would lie, right? So here you would be talking about, you have to design for slow internet connections. So make that a part of your design identity for sure. Uh, Enable auto saving data as much as possible. Also, make sure that you have the possibility of working offline. Maybe you are working on some clinical module, a diagnosis module for something, and then not everything needs to be constantly uploaded, or even if it is, then make sure that you have a backup, and you are able to batch upload data. Make sure that things are packed as much as a clinical decision support algorithms are concerned, because they can really help you make quick decisions about going ahead with risk scores, or maybe triaging your patient population as quickly as possible. Yeah, so you are already, when you are speaking to your patient directly, maybe in just those 2 minutes, you already have counters and pointers in order to suggest certain things or certain takeaways that absolutely make sense for them. Then use template based data entry, like make sure that you're using autocomplete as much as you can. You're only making sure that whatever you have to key in or input only captures mandatory fields, nothing else. I mean, make sure what is mandatory at this point of time, and just stick to that. And not let me give an example of patient registration, right? Not every registration has to happen via a registration desk in the hospital, or like a kiosk in the hospital. It can also happen outside of the hospital through technologies like SMSs and IVRs and things like that. Moving on. Yeah. And what constitutes easy facilitation and maintenance of these solutions? So here the principle would be maximum uptime with minimum resource. And remember that resource is always a challenge. So in this case, how do we really rethink the help UX, right? We are pretty used to troubleshooting, but how can you make troubleshooting more visual, more video based, more self-help based, more remote based, and making sure that even things before things are solved even before that, uh, even before a error, or for example something goes wrong as well. Then very important also to show the performance of your devices or equipments or your solutions very explicitly. So if things are okay and up and running, you explicitly show that things are up and running. If not, it's very important to show when things are going wrong, because then it would also send over visual cues to you in order for you to take immediate action. And definitely there will be certain preventive and educational warning and tips. And it's more about making sure that you are going ahead and making everyone a part of this journey, a part of help maintenance, and a part of making sure that the devices are up and running in terms of upkeep. Now coming to the UX, maybe just my last two slides over here. How does the UX change as well? Because here we are designing for maybe semi-literate caregivers, and the first one is a no-brainer, right? Use audiovisual interfaces as much as you can, because here we are talking about effective outcome, but with the lowest of errors. I mean, just because someone isn't really fully in tune with your latest digital technology, that doesn't mean that there has to be a scope of error in this case. So make sure that you have the right guided wizards, so that step by step take them through whatever is necessary, making sure that iconography is really relevant and meaningful, because a lot of times we just assume that things are understandable and are comprehensible, but we have seen that more often than not, icons don't really make sense. So over here, they look for pretty detailed illustrations of things, and that's when things start to change over here as well. And most importantly, not to forget, have a very clear and uncluttered layout, and focus on the minimum as much as possible. Uh, Again, the last point over here is look into prevention that is outside of the clinic premise. Don't just look for clinic or like a hospital in order to triage your population. So indeed, in this case, we have to then design for outdoors or daylight, yeah, making sure that, of course, we have been having these interesting solutions and artifacts more conducive to a clinic's chamber, or maybe like a hospital chamber. But in this case, be ready to design for outdoors and daylight. Leverage free internet, because that's also possible in a lot of regions and a lot of countries, taking into consideration, of course, privacy. But you need to make sure that you have the right AI in place to chuck that out, but also making sure that you are allowing registration outside of the hospital and moving forward. And last but not the least, what does it mean for the patient, right? Here it is the principle that we would be sticking to is health seeking behavior being a way of life. So like I said, in terms of tonality, make sure that that it is more benefits focused rather than consequence focused, because that kind of tonality goes a long way. And when we're talking about population that really needs to be a part of this care, show them the benefits. And also make sure that there are different compliance drivers for different patient types. Not everyone is same, and that's the whole crux of this discussion. Even though we are talking about one region, there are different segments of taking them through. And definitely think about the how often would you want them to engage in your back and forth interactions through your services, solutions, and your patients. Because we have also seen that a lot of time push messages rather than pulling of information, or push advices rather than pulling of information, works a lot better, because here you are driving them, you are pushing them, you are helping them and guiding them to move forward with in their healthcare journey. And last but not the least, making sure that you are tracking adherence rate. So based on the treatment, based on the lifestyle suggestions, etc., based on also the kind of medications that you're set to take, make sure that you're driving and showing them the benefits of adherence, and also the implications of what non-adherent to one particular pill intake can mean to your world. So with that, I would like to conclude my presentation. And indeed, like you see, healthcare is a topic perhaps close to all of our heart. And it brings us closer to the factors that we as designers want to really practice, which is about empathy, which is about making sure that we are designing for all. And I would love to hear from all of you again, either through the question answer session right now, also afterwards. If you're interested in healthcare, just give me a shout and we'll love to have this conversation going forward. So that's it.
Thank you. Thank you, Shaon. It was, can you hear me? Yeah.
Yes.
Very informative and very interesting work. Anyway, the Philips, we all know that one of the finest company which is into the healthcare, and we have grown with Philips and its activities which are happening in different part of the world. Just few things like the COVID has caught us off guard, and obviously the whole definition of healthcare, in fact a lot of unprecedented social experiments also have happened during the this pandemic period which is happening. What kind of experimentation you have initiated during this time, uh, in the area of preventive healthcare, or dealing with the way things have, meaning like in a very ambiguous situation where we are heading, what this COVID is going to really hit on phase one, phase two, and all. So, what kind of approach which has been taken in Philips lab?
Sure, would love to answer that, Pradyumna. Indeed, it has taken us unaware, and though we were, deeply involved in remote care and remote patient monitoring and things like that, the sheer mass and volume of this delivery model was definitely surprising, and we were not prepared for it. But if we do go back to the original principles, right, like when we look into our healthcare continuum, it starts from healthy living, and then you go to prevention, then you go to screening, and then diagnosis, treatment, and then you're back to home and recovering. So the whole aspect of end-to-end care, right, like I mentioned, designing for people who are not even sick, designing for people who are healthy, that mindset has really helped us, I would say, because here it is so much about monitoring, so much about making sure that you have the right environment, right aspects of healthcare, and also making sure that you're flagging the slightest of discrepancies of the vitals that you have. So going back to not just making sure that you're connected. So we have a lot of modules around connected care. So connected care happens to be one of the, a cluster that we are deeply investing in. But having said that, there are also modules related to, let's say, we have a little device called the health dots, where it's a patch, and then when once a person leaves the hospital premise, you are constantly monitoring their vitals. But having said that, there are also aspects where, there are still pertinent aspects to compliance and adherence that has become a talking point. And it is to do, we also realize that the value of healthy living deeply lies in the behavior change as well. Only if you enable behavior change, you can actually facilitate healthy living. And like I said, there are, like you asked me, there are certain experiments around healthy living and behavior change. It's not an easy topic, right? um, so indeed, I think in what our greatest learning has been about the implications. So showing disease progression even before something has hit you. So making data very visual, right? Making sure that you are already telling them about consequences that can impact you if certain treatment protocols are not taken care. That kind of visual delivery of consultation and also storytelling, that has helped us a lot, I would say.
Thank you. I think it's wonderful because healthcare is something, that all designers, they always look into this particular area where the system approach, design thinking approach, a lot of things are there. We don't have much time, but otherwise offline sometime we should discuss that
Definitely.
how Philips is engaging institutions, how Philips is working with co-creation with the authorities and other people. Lots of interesting thing I'm sure you would like to share in future. So we know about your the mail address and also we'll certainly touch with you.
For
So thank you
sure.
very much. Indeed, pleasure listening to
Thank you.
you, and I think there is very interesting work which you are carrying on in
Thanks,
Philips.
Pradyumna. Sure, would love to catch up. Sure.
Pooja, over to you.
Thank you. Thank you, Ms. Sengupta, and thank you, Professor Vyas.